Hello everyone, my name is Kaylee Knight. I am a NICU nurse at the University of Maryland Medical Center. Thank you for attending our neonatal workshop today. Today our lecture is on patent ductus arteriosus, also known as PDA. The goal of this lecture is for NICU nurses to gain a better understanding into what a PDA is and the treatment and management of all that encompasses a PDA. So we're going to achieve that goal through our 4 objectives today. At the end of this presentation, the learner will be able to describe what a PDA is, list the risk factors for a PDA, identify signs and symptoms of a PDA, and discuss treatment options for a PDA. So what is a PDA? Well, a PDA, you can see over here on the left side, this is a normal heart, and on the right side here, the PDA is a large vessel which connects the pulmonary arteries to the aorta. It accounts for about 5 to 10% of congenital heart defects in neonates. In utero, a PDA is necessary. You can take a better look at this diagram here in your notes, but I'll show you all here. So, in utero, the placenta does the oxygenating of the blood for us. So the placental vein will bring our oxygenated blood into the right side of the heart, to the right atrium, right ventricle, into the pulmonary arteries, and the PDA will allow blood to shunt from the right side to the left side of the heart, bypassing the lungs into the aorta, and allow the blood to go, oxygenated blood to go out to the body for systemic circulation. Now what happens after the baby is born, the cord is clamped, pulmonary vascular resistance drops, and systemic vascular resistance rises. This will allow blood to go to the lungs to be oxygenated, and as oxygenated blood flows through the heart, that PDA is very sensitive to oxygen, so it will start to close in the first 1 to 3 days of life. However, if the neonate doesn't have that systemic vascular resistance rise and it stays low, and that pulmonary vascular resistance doesn't drop and it stays high, that shunting of blood will change, and it will now shunt from left to right. So that blood that is going to the lungs to be oxygenated and returning to the left side of the heart, going out through the aorta, will shunt back across into the pulmonary artery, recirculating into the respiratory system where it's already been. So now this can cause some serious problems for our neonate. After birth, the PDA, if it's very small, may be asymptomatic. These neonates will be monitored. It'll usually close in the first year of life. Hemodynamically significant PDAs are large in size, have a lot of shunting, and those are the neonates that we're going to focus on today. They may also have a congenital heart defect. This can include transposition of the great vessels, coarction of the aorta, pulmonary atresia. These things all require a PDA to get blood to the lungs, and those neonates would receive medications to keep that PDA open. Today we're going to focus on those hemodynamically significant PDAs. What are the risk factors for a PDA? So premature infants, they have immature lung structures, they're not able to oxygenate well. This can cause that PDA to stay open. Respiratory cause, so respiratory distress syndrome or surfactant administration, those can cause the PDA to stay open. Fluid overload, the heart and the lungs are already working really hard. This can cause some more backup and cause that PDA to stay open. Asphyxia and a high altitude, both cases where that's low oxygen within the neonate, and that's the oxygen is what causes that PDA to close. So low oxygen, the PDA will stay open. Genetics, so trisomy 13, 18, and 21 can all cause that PDA to stay open. Congenital heart defects, like we just discussed on the last slide, and also congenital rubella is an infection associated with that PDA staying open. How do these neonates present? So they may or may not have these signs and symptoms. A murmur will be a machine-like sound heard at the 2nd to 3rd intercostal space of the upper left sternal border. It may radiate to the axilla and may also softly be heard on the back. Widening pulse pressures, so a big difference between the systolic and diastolic blood pressure. This can also cause bounding peripheral pulses. Hypotension, so a low MAP. This is especially true for those extremely and very low birth weight infants. Respiratory issues, again, for those extremely low birth weight and very low birth weight neonates. They could have respiratory issues where they're not able to oxygenate well, and that can cause some fluid overload in the lungs, and that will present with our PDA. Tachycardia, so a heart rate greater than 170, respiratory rate greater than 70. These systems, the heart and the lungs, are working really hard to get that blood circulated properly, and that PDA is not allowing it to. And then also metabolic acidosis, simply explained by anything other than those kidneys aren't getting enough oxygenated blood. So how are we going to diagnose this infant? We're going to do an echocardiogram. That's the gold standard, usually around day of life 5, because we want to give that PDA a chance to close on its own in those first few days. It'll give us a great picture of what the heart looks like, how big the PDA is, the degree of shunting, and also any other heart issues that may be going on in that neonate. A chest x-ray may be helpful a little bit further down the line for a neonate that we know already has a PDA. That's going to show us when the lungs start to be affected, the fluid overload, and also if we take a look at our diagram again, so because the blood is being shunted back into the pulmonary arteries here, some fluid backup can happen in the right ventricle, causing right ventricular hypertrophy and lead to congestive heart failure. So the x-ray will be helpful when we're further along in our PDA course. What does this mean for the neonate? Well, we're going to have an increase in pulmonary circulation, more blood going to the lungs. This can cause pulmonary hemorrhage, bronchopulmonary dysplasia, and increased fluid on the lungs, which can cause some respiratory issues. They're also going to have a decreased systemic circulation, so not enough blood out to the body. This leads to cerebral hypoperfusion, which can cause intraventricular hemorrhage and periventricular leukomalacia. Also, GI hypoperfusion can lead to spontaneous perforation or necrotizing enterocolitis, and then renal hyperperfusion. So a volume overload in the body, low urine output, kidneys can't get that fluid out. And all of these combined can lead to failure to thrive. So this infant doesn't eat well, can't gain weight, and can have some serious problems. How are we going to manage these infants? We're going to give them the respiratory support they need, whether that be intubation, nasal cannula, CPAP, whatever they require. Fluid restriction, so they're already being fluid overloaded, the systems can't work right. We don't want to put more stress on the neonate. And also hematocrit, so maintaining a hematocrit from 40 to 45% can help decrease that degree of shunting across that PDA. Treatment options, we have pharmacological and surgical. We're first going to discuss our pharmacological options. So indomethacin, historically the drug of choice, given 3 IV doses, 12 to 24 hours apart, and it can be spaced out longer with smaller doses. These infants can receive 2 courses if necessary, so if they get one, it doesn't work, they can get another. However, it does have some serious effects. So platelet dysfunction, they're at risk for bleeding. Renal effects, so they have renal hyperperfusion, low urine output, and cerebral effects, cerebral hypoperfusion, increased risk for intraventricular hemorrhage, and then gastrointestinal effects. So these infants are at risk for GI bleeding and necrotizing enterocolitis. This has led to more use of ibuprofen. This can be given IV or PO, 3 doses, 24 to 48 hours apart usually. It has less renal and GI effects, however, it does have similar cerebral effects, so still at increased risk for intraventricular hemorrhage. And studies are showing that maybe ibuprofen is a little bit more similar to indomethacin than we originally thought. So a lot of docs have chosen acetaminophen as our treatment option. This can also be given IV or PO, 6 to 8 hours apart for about 3 to 7 days, depending on the dosage. It essentially has no renal, GI, or platelet effects. However, it can be very liver toxic, so we want to monitor liver levels in these infants, and if they have an underlying liver condition, we wouldn't want to give them this medication. Acetaminophen can also be used as rescue therapy. So if your infant already got indomethacin, it didn't work, we can still try to give them acetaminophen to close that PDA. Now, pharmacological options don't work, or they're contraindicated in our neonate, we can use surgical ligation. So this is when a metal clip or a tie will be used to close that PDA surgically. And then we would do a post-echocardiogram to make sure that PDA is closed, no blood is shunting across that PDA anymore. However, we do need to watch for adverse effects in these infants. So vocal cord paralysis, bronchopulmonary dysplasia, worsened neurodevelopment, increased risk for necrotizing enterocolitis, intraventricular hemorrhage, and retinopathy of prematurity. So these are all things we need to watch for in these infants that have surgical ligation. Transcatheter device. This is newer in the neonatal population, mostly used in adults and children that have to have a PDA closure. However, it is starting to be pioneered in these very little neonates. It's done in the cath lab. Access is gained through the femoral artery or vein, and using fluoroscopy or ultrasound, they'll go and they'll put a plug in that PDA, a little balloon. So then we would do a post-echocardiogram to make sure that balloon is fully closing the PDA and no blood is shunting across it anymore. Since it is new in neonates, adverse effects and success is still being studied, but it looks very promising. Today's takeaways before we get into a case study, I want you guys to remember that circulation change. So in utero, we're skipping the lungs, blood is shunting from the right to left side. After the baby is born, cord is clamped. If that vascular resistance change doesn't occur, that shunt happens from left to right now, and we're fluid overloading the lungs, not enough out to the body. PDA presentation, what are those signs and symptoms? The gold standard diagnosis, echocardiogram. Implications, that increase in pulmonary circulation, decrease in systemic circulation, critically think, how is that going to affect my neonate? And also our treatment options, so pharmacological options and surgical options. So now we're going to take a look at a case study. So a patient, male newborn, delivered prematurely at 26 weeks via C-section, secondary to maternal HELLP syndrome and hypertensive crisis. His APGARs were 1, 3, 4, and 6. He was intubated in the delivery room, given artificial surfactant, as well as 2 doses of epinephrine via the endotracheal tube. He was intubated for the first 5 days of life on moderate low ventilator support. Extubation to non-invasive positive pressure ventilation occurred on day of life 5, but due to increased bradycardia and desaturation events, he required re-intubation 12 hours later. On day of life 6, the same day as re-intubation, the infant had a murmur on auscultation, bounding pulses, and widening pulse pressures greater than 30. So some questions. What risk factors were present in this neonate? Yes, Angie?
He was premature at 26 weeks, needing respiratory support with intubation, and he received surfactant.
Right, so this neonate was very premature, 26 weeks, had to be intubated at birth and then re-intubated, and also that surfactant that we discussed can cause that PDA to stay open. So what signs and symptoms did we see in this neonate? Go ahead.
He had a loud murmur, bounding pulses, and widening pulse pressures.
Right, so those widening pulse pressures can cause those bounding peripheral pulses. He held that loud murmur on day of life 6, and like we said, we wanted that PDA closes usually in those first 1 to 3 days, so that's typically when it would present. How are we going to diagnose this neonate? Go ahead.
The gold standard echocardiogram should be used to diagnose this neonate.
Right, so that echocardiogram on day of life 5 or 6, we want to give that PDA a chance to close on its own. That's going to give us a great picture of what's going on with this neonate's heart. So we find that this infant has a PDA. What are our treatment options? Angie?
Medications could be used first. Indomethacin, ibuprofen, or acetaminophen. Acetaminophen would probably be the best due to this neonate's risk factors. If that doesn't work, surgical ligation or a transcatheter device could be used.
Great. So this neonate was treated with acetaminophen just because he due to his prematurity and all of his pre-existing risk factors. The indomethacin ibuprofen can be really detrimental. Acetaminophen would be perfect for this neonate. He actually did require surgical ligation afterwards. The acetaminophen did not close the PDA, and they used the classic surgical ligation at about 2 months of life to close this PDA. This concludes our lecture for today. I hope that you all learned a lot about patent ductus arteriosus, and thank you so much for attending our neonatal workshop.